Good afternoon and welcome to today's webinar, The Potential Impact of the Midterm Elections on Public Health, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Strong, the Digital Marketing Coordinator at the Network for Public Health Law's National Office, and I'll be your host for today's webinar. Please feel free to submit questions at any time by using the Q&A tab on the right-hand side of your screen. We strongly encourage attendee participation in our webinars and would love to hear some of the thoughts and questions that you have. So all you need to do to submit a question is click on the Q&A tab, select all panelists from the Ask drop-down menu, and submit your question. As you do not see the Q&A tab available, click on the button with 3 dots highlighted in the picture. Your moderator for today's webinar is Chelsea Gulinson. Chelsea is a staff attorney at the Network for Public Health Law's Western Region Office and a research scholar with the Center for Public Health Law and Policy at Arizona State University. Her work focuses on public health emergencies, the opioid crisis, reproductive health and technology, obesity prevention, and food security. Chelsea will be leading us through the rest of today's webinar, so Chelsea, over to you.
Thank you, Charles, for the introduction. Public health issues were at the forefront of the midterm elections, from reproductive health services to the Affordable Care Act to Medicaid expansion. Candidates seeking to retain their seat and candidates running for the first time heavily campaigned on important public health topics. I'm very excited to introduce our speakers who will be discussing the midterm election results and their potential impacts on public health. First, we have Sarah Summers, who is Managing Attorney of the Network for Public Health Law's Southeastern Region Office and the National Health Law Program's North Carolina Office. She specializes in litigation and litigation support intended to advance access to quality health care for low-income and other underserved people. Working with health and poverty law advocates across the country, she engages in litigation, research, writing, and training on the Medicaid program, the Americans with Disabilities Act, and the Affordable Care Act, among other issues. Elizabeth McCammon is staff attorney in the National Health Law Program's Washington, D.C. offices, where she focuses on federal and state reproductive health policies affecting coverage, access, and care quality in both Medicaid and private insurance. In previous positions, Liz has provided technical assistance for the implementation of Medicaid, CHIP, and public health initiatives, as well as drafting regulatory policies and protocols on hormonal contraception. Without further ado, let's begin our webinar. Sarah, you have the floor.
Thank you, Chelsea, and thanks everyone for joining us today. I'm going to start out by talking about the broader impacts of the midterm election on public health, and then I will turn it over to Liz to hone in specifically on reproductive health issues. And I'm probably not telling anyone on the phone anything they don't know, but for the first time in 8 years, the control of the House of Representatives has switched to the Democratic Party from the Republican Party. Obviously, that means that there is divided control over the federal government. The executive remains Republican, the Senate remains Republican, but the House of Representatives is now controlled solidly by the Democrats. And so what this means is that there are not going to be Democratic championed proposals that are likely to become law. Rather, what it means is that the legislative agenda that was originally either proposed or feared on the part of public health advocates is not going to come to pass. The repeal of the Affordable Care Act, which was attempted many times during the first 2 years of this administration, is certainly not going to pass now. They're not going to get that through the Democratic House of Representatives. And everything that is encompassed in the ACA remains will remain on the books for the immediate future. So people outside of the public health world don't focus that much on this, but as many people on the call know, there are a whole host of provisions in the Affordable Care Act aimed at developing the public health workforce and other, aimed at providing support for public health initiatives. And so those, to the extent that they haven't been, defunded, are still going to exist, and there's a possibility that some of them might have funding restored, depending on how strategic the House of Representatives can be. One of the great fears that we had was that if the House remained in Republican control, that one of the projects, the long-held wishes of the conservatives in Congress was that Medicaid would be transformed from an entitlement to a block grant. Essentially, Medicaid is an entitlement because of a couple provisions in the Medicaid statute that essentially provide that a person who fits the eligibility categories in their state for their Medicaid program gets coverage, full stop. There can't be waiting lists, there can't be limits on funding except due to particular rules or medical necessity or the coverage rules for services. Meaning that, contrast that with the Children's Health Insurance Program, which some of you may have been in states where they suspended enrollment or began waiting lists because the funding had run out at the federal government, at the federal level. So Medicaid block grants, we're safe from statutory block grants for a while. And then there are Medicaid work requirements. As those of you who are avid webinar followers for the network, you may have heard a presentation that we did earlier this year talking about Medicaid work requirements. And just as a quick recap of how that happens, the executive branch, if requested, can provide permission to states to require enrollees to work as in order to get Medicaid coverage. This is not in the statute, and so far there's been at least one judge, federal judge, who's held that it is not consistent with the objectives of the Medicaid statute to do so. But the federal government has granted permission to a handful of states, allowing them to do this. We'll talk about the executive aspect of that in a minute, but what we had, what many observers had thought was that because this, the idea of requiring people to work in exchange for getting publicly funded health insurance had seemed to take hold among the Republicans, there was a distinct possibility that once they were in office, they would amend the statute to allow states to require people to work. But once again, none of these things are going to come to pass through federal legislation. Oops, wrong way there. All right, so at the state government level, there were a lot of changes as well. These are governorships and legislatures that were controlled by the Republican Party, but are now controlled by the Democratic Party. And lest you think I'm dwelling too much on party affiliation, there's a strong correlation between expanding Medicaid and having a Democratic control of the governorship or legislature, and in contrast, for example, requiring work requirements in Medicaid with having Republican control over the governors or legislatures. Now, in a minute, Liz will talk about the implications for reproductive health, which are myriad, but in this case, we now have just take an example of Maine, a state where the voters passed an initiative requiring the state to expand Medicaid, but the governor fought it with every tool at his disposal for several years, including simply refusing to do it. And a lawsuit was filed requiring him to do so, yet even though the parties prevailed, that still is in limbo. He's leaving office, and now a different party governor is coming in, so presumably they'll be able to get to do that. With regard to the legislatures, just to give you one example there, in New Hampshire, the legislature required the state Medicaid agency to seek permission from the federal government to impose work requirements on the Medicaid expansion population. However, the control of the legislature, both the House and the Senate, has flipped to the other party. And so that it remains to be seen what that means going forward, but it is likely to have implications for issues to do with Medicaid and Medicaid expansion and work requirements. Speaking of ballot initiatives, as voters did in Maine a couple of years ago, voters in Utah, Idaho, and Nebraska voted to require their states to expand Medicaid. I apologize to everybody. I'm fighting a cold, and so my voice may sound a little bit shaky. Anyway, the little bubbles that you see here are have to do with the party affiliation of people in these states. These are states that are both what are sometimes referred to as red states, but this is the margin in red of victory of President Trump in each of those states. Yet, in those same states, only 2 years later, this is the margin of victory for the Medicaid expansion. 6% in Nebraska, 8% in Utah, and then 22% in Idaho. Particularly in Idaho, that's really a ringing endorsement of this policy. So that means that there are plenty of people who may identify as conservative or Republican, but who see the public health benefit of providing coverage to this segment of the population. Now, it remains to be seen how rocky the road to implementation will be. For example, in Idaho, just a couple days after the election, a couple individuals filed suit arguing that the Idaho expansion was unconstitutional under the state constitution. However, there will likely be a fight on behalf of the state to try to keep that. So we'll see what happens there. All right. So as I mentioned earlier, and as you probably know, the Senate remains unchanged. So what that means for legislation obviously means an impasse between the House and the Senate on anything that is controversial between the parties, and also that appointment of judges will continue. And excuse me. I'm so sorry, everybody. There are plenty of lawsuits that are aimed at striking down the Affordable Care Act, including one in Texas. And so the judiciary will continue in that direction. And finally, the executive actions will continue. They'll continue to approve work requirements. People are probably aware of the regulations that I'm so sorry. I'm just going to have you pass this to Liz so I can, this is my last slide, so I can stop coughing at people.
Okay, Liz, if you want to go ahead and get started. Yeah.
Okay. Thanks, everyone. So I am going to talk specifically about how the midterm election results may impact reproductive health. So this slide tells you all about who I am and where you can contact me. And also, we just revamped our website, so I would not be a good employee without giving that a proper plug. So go to healthlaw.org and check out some of our new resources. And with that, I would like to ground us in some frameworks. And this is probably going to be very repetitive for a lot of people, but I wouldn't be a proper public health researcher and advocate if I did not kind of lay out my assumptions. So you may be asking, what do public health and health equity have to do with reproductive justice? And I'd like to fill in some of the gaps. So our mission in public health, and for me as an advocate for the healthcare safety net, is to protect and promote the health of all people. Public health is traditionally grounded in prevention and the need for moving health interventions upstream. But even as overall public health statistics have improved in many areas, we still see persistent health inequities. And for this reason, health equity is increasingly identified as a principal goal to be achieved through public health policies and activities. Next, I'd like to differentiate among the reproductive health rights and justice frameworks and make the case for including them in a public health analysis. So reproductive rights is a legal and advocacy-based framework that protects women's legal rights to reproductive health care, and in particular to abortion care. The focus here is on the legal protection and enforcement of laws intended to protect the legal right to reproductive health care. Reproductive health focuses on service delivery. It addresses the reproductive health needs of women and focuses on a lack of healthcare services, information, as well as research and health data. The reproductive health framework does not tend to address the root causes of social inequality. And reproductive justice is an intersectional framework which focuses on movement building. It focuses on the idea that reproductive oppression is the result of the intersections of multiple oppressions, and elevates the issues facing low-income women, women of color, women with disabilities, and LGBTQ people. But even though I have them here on a pyramid, these categories are more fluid than rigid, and a single advocate or organization can belong to multiple categories, and it's not a hierarchy. So NHELP itself engages in reproductive health work using a reproductive justice lens. And so reproductive health services are critical to health outcomes, well-being, and economic security, and this is supported in a wide range of public health data. But reproductive health services are still consistently carved out of healthcare under constant attack at the federal and state levels and receive inadequate, if any, insurance coverage. These barriers result in such health inequities as furthering poverty, racial disparities in maternal mortality, and higher rates of STIs and unintended pregnancy in communities of color. And so whenever we see inequities, we can deploy health equity strategies. And reproductive health equity can be achieved when all people are able to have a responsible, satisfying, and safe sex life, and have the capacity to reproduce and the freedom to decide if, when, and how often to do so. So now that I've gone through that spiel, I'll say that my goal in this webinar is to discuss how the 2018 midterm elections shone a spotlight on ways in which national and state policies prioritize or deprioritize reproductive health, and ways that the public health community can support health equity and health justice strategies for such a crucial aspect of the human experience. And I'm going to be talking about 3 areas of the midterm elections. The first is ballot initiatives, which produce mixed results, state legislatures, which remain more important than ever, and governor's offices, which resulted in a lot of gains, but there is still some residual damage from previous governors that we'll have to contend with. All right, so moving along to ballot initiatives. Not all states have the ability to put things directly onto the ballots, but for those that do, it's a very crucial strategy for enacting the will of the people. So I'm going to highlight 5 of them, 3 of which are directly on abortion coverage and abortion care, 2 of which touch on broader reproductive justice issues. All right, the first is Oregon Measure 106. This measure would have taken away abortion coverage from public employees and Medicaid enrollees under the guise that it's using public funds to quote unquote promote abortion. And so this this ballot initiative was rejected, 64.5% against, which is a pretty strong majority, not in favor of these restrictions. The next is West Virginia Amendment 1. This is basically a direct challenge to a previous state Supreme court decision that mandated abortion coverage in Medicaid under the West Virginia Constitution. So this amendment, unfortunately, did pass, and it states that no public funds can be used for abortion in any circumstance. On the face of its language, it does not include exceptions for rape, incest, fetal anomaly, or threats to the women's health, which is in conflict with the already extremely restrictive and racist Hyde Amendment. But we have yet to see exactly how the Medicaid agency will enforce that, and I think that will be determinative in whether litigation is filed. And again, unfortunately, that passed by 51.7% in favor. So close. That one's really a heartbreaker. And moving on to devastation, we have Alabama Amendment 2, which added personhood language to the Alabama state constitution. For those of you who may not be familiar with the vague term personhood, it elevates fetuses to have the same legal rights as all other people. And the passage of Amendment 2 creates a trigger band that would basically completely outlaw abortion in the state immediately should Roe v. Wade fall under a current or future Supreme Court. This passed by a bit more of a margin, 59%, which I think can also be attributed to the fact that the results may not be as immediate as the West Virginia, where it really started hurting people immediately, because we've learned that the Medicaid agency in West Virginia stopped reimbursement for all abortion services the night of the election. And just so that we're not completely getting depressed on this webinar, I'd like to really highlight some crucial victories that show that reproductive health can be a winning issue for a lot of people, depending on how you frame it and how you garner your support. So in Nevada, state question 2 passed, 56% in favor, and Nevada state question 2 eliminated the tampon tax, or sometimes called the pink tax. Essentially makes menstrual products like tampons and sanitary pads exempt from the state sales tax. So other medical devices like bandages and prosthetics were already exempt from the state tax. So this brings these products in line with the medical device standards. And this is estimated to save women and people who menstruate between $4.96 and $7.11 million annually. And then finally, Massachusetts question 3. This is the biggest margin of passage of all of the ballot initiatives that I've mentioned, passing by 69%. And what this does is keep a 2016 law that the state legislature had passed to ban discrimination based on gender identity in public accommodations. So federal, and to give an understanding of why it was important for this federal law, or for this state law to be upheld, federal law does not explicitly prohibit discrimination based on gender identity in any setting. The Health and Human Services Agency under a previous administration had interpreted 1557 of the ACA to prohibit healthcare discrimination based on gender identity or pregnancy termination. But that regulation is currently unenforceable by court order, and probably the federal administration is not the most reliable enforcer of that. Anyway, so state anti-discrimination policies are very critical public health tools, and it's very exciting to see that that one remains in effect. All right, I'm going to take a sip of water and then move along to state legislatures. Okay. So state legislatures are a very critical vehicle for advancing proactive public health legislation. And they remain a critical tool now more than ever. But I want to preface this part of the presentation by saying that reproductive health and public health are not Democratic or Republican issues. They are health and human rights issues, and they're supported by the public health evidence base. However, the Republican Party has inserted restrictions on reproductive health services into its party platform, and relevant policy tends to pass or fail along party lines. And for this reason, it is useful and important for us to identify this trend and slice some of the midterm data by party lines to hypothesize what this may mean for both proactive and defensive reproductive health advocacy. As you can see, state senates after the midterms have swung blue in a number of key swing states, namely Colorado, Connecticut, Maine, Minnesota, New Hampshire, New York, North Carolina, Michigan, and Pennsylvania. And just a note, in the New York Senate, the Democrats have numerically had the majority there already, but for years there has been a group of Democrats who had broken off to caucus together and team up with Republicans, and the non-Republican caucus now has the majority. And in the Connecticut Senate, there was a split, but a Democratic legislature broke the tie, and now the Democrats fully control. So what I hypothesize this will mean is that, especially in states with new Democratic trifectas, you will see proactive legislation that expands insurance coverage and reimbursement for reproductive health services and codifies the right to reproductive freedom into state policy. Colorado and New York are examples of states that have tried to pass contraceptive equity laws previously. And if you're unfamiliar with contraceptive equity laws, I'll give another plug for our website that if you go in and search contraceptive equity, I have a nice Q&A fact sheet that will pop up. But in these states, now that they have such strong majorities, I expect that this legislation will go extremely far, if not definitely pass and become law. Other proactive trends that I predict we will see in these states and other majority blue states would be codifying the ACA's birth control benefit and other pieces of the ACA's preventive health services requirements, codifying the freedom to choose abortion care into state constitutions and state statutes, and mandating maternal mortality review committees. And in a state like North Carolina, which has broken GOP supermajorities in the House and Senate, but still has an anti-choice governor, you may see some of these proactive pieces of legislation pass, but then be vetoed. And while I didn't really focus as much on midterm losses for state legislatures, especially in states that have conservative supermajorities, we can unfortunately expect what we've been seeing since 2011, which is the targeted regulation of abortion providers, or TRAP laws, abortion reason bans, which basically investigate the motives of the person seeking an abortion and seek to prevent some of them, depending on what answers that person gives. Method bans, criminalization of self-induction, gestation limits, and exclusion of reproductive health services from public programs, including Medicaid. And this is really important to recognize because it stigmatizes reproductive health from the rest of healthcare, and that is a public health issue. And so finally, I'd like to move on to governor's offices, where we've seen some important gains, but has also created some major fights. So important pro-health and choice governors were elected in a lot of the states I mentioned on the previous slide: Colorado, Connecticut, Illinois, Kansas, Maine, Michigan, Nevada, New Mexico, New York, and Wisconsin. This is really important for advocates because even where a state's legislative branch is not supportive of reproductive health and health justice, the executive branch has many options at its disposal to protect and advance care. And I'm going to share 3 major avenues for change within the executive branch that public health advocates can engage in, and that's promoting regulations, issuing health plan guidance, and submitting a Medicaid state plan. In most states, there are 1 or 2 agencies that oversee health plans and have statutory authority to issue regulations governing some health plans within the state. For example, in 2018, New York's Department of Health Services promulgated regulations that require plans to cover all FDA-approved contraception with no copay. And now with the changes in the New York State Senate, that regulation can essentially serve as a blueprint for state legislation. Another way that pro-choice and pro-health governors can advance proactive policy is through health plan guidance, such as all plan letters. And these types of letters provide clarification regarding different preventive services, and they also, well, they can be about any services, but in terms of reproductive health, a lot of it is preventive services, and include official sub-regulatory policy text. And one example of this is that in 2016, California's Department of Healthcare Services issued an all-plan letter to all Medi-Cal managed care health plans, making clear that managed care plans must pay for up to 13 cycles of contraceptives if billed by a qualifying provider. So that was their interpretation of what a 12-month supply means under the state contraceptive equity law. And finally, the executive branch of a state has some discretion to determine what family planning services and supplies to cover in their Medicaid programs. A Medicaid state plan is an agreement between a state and the federal government describing how that state administers its Medicaid program. When a state is planning to make a change to its program, policies, or operational approach, states send state plan amendments, or SPAs, which sound much more appealing, to the Centers for Medicare and Medicaid Services for review and approval. And states can use a SPA to do things such as unbundle immediate postpartum LARC from the global labor and delivery fee, which incentivizes providers to offer the service. And that's something that we've seen in a number of states. And these are all really positive things that I'm so glad that I get to share with you, but at the same time, I would be remiss if I didn't let you know how deprioritized public health is by some administrations. So while the executive branches in states have many options to promote care, they unfortunately also have options to hinder care. And, excuse me, it's contagious, Sarah. And on the next slide, I will do a deep dive into some recent executive actions by state governors that threaten public health by attacking reproductive health services. All right, so as some background, there is a part of the Medicaid Act that requires participating states to include in their plans the ability of individuals to obtain services from any qualified provider. However, states hostile to reproductive health have attempted to kick abortion providers and other clinicians, such as Planned Parenthood clinicians, out of the state Medicaid program, claiming that they are not qualified because they provide these services. So, for example, in 2015, Arkansas attempted to terminate Planned Parenthood from its Medicaid program, which led to a very unfortunate Eighth Circuit case called Doe v. Gillespie. And now, with Kansas and Louisiana also attempting to terminate Planned Parenthood from their Medicaid program, the Supreme Court is actually conferencing tomorrow on whether there is a private right of action under Section 1983 of the Medicaid Act to enforce the Medicaid Act when the deprivation at issue is either being excluded as a qualified provider or being a Medicaid enrollee whose provider is being excluded. This says up for conference 11:30. That's true. It was up for conference last week. It is actually now again up for conference tomorrow, as I mentioned, and that will be the 9th time that is up for conference. So all I can say is that this is an extremely important case to keep your eye on, and it shows why state elections matter so much when it comes to public health. All right, so thank you for bearing with me. I want to end by acknowledging that most of these post-election updates focused on the politics of insurance coverage. And insurance coverage and public health are inextricably intertwined and very important, but comprehensive insurance coverage does not create health equity. And so I encourage all of us to kind of use a health justice and a reproductive justice framework in our work going forward to advance person-centered care. And I'm going to turn it back over to our moderator so that we can answer questions.
Thank you so much, Liz, and thank you as well, Sarah, for your incredible insight. I'm excited that we can now begin the Q&A section. So I just want to remind everyone, send in your questions. We'll filter through them and be sure to get them to our fantastic panelists. So while those come in, why don't I start us off with a couple, and then Liz and Sarah, either of you feel free to answer any or both. If people have some directed towards you, I'll be sure to mention that. So going off of that case that's facing the Supreme Court tomorrow, do you think that certiorari will be granted? Given that it's gone up now several times, what do you think is going to happen?
Liz, do you want me to speak to that?
Yeah, my thoughts are different than yours, and I'll let you know. But yes, please, Sarah is our court expert.
Okay. Well, just the backstory on this is that Medicaid provisions used to be enforceable in court with relative ease until the 1990s when theories were advanced about why individuals shouldn't be able to bring court actions to enforce, various requirements. One of the requirements in Medicaid is that any willing provider who meets the state criteria should be able to, for the kind of provider, should be able to provide Medicaid services. And these initiatives, these actions by the state governments where they exclude Planned Parenthood, generally run afoul of that Medicaid provision. And as Liz mentioned, Medicaid only covers abortions under very limited circumstances because of the Hyde Amendment. So what this really means is that a variety of family planning services, particularly birth control, are going to be unavailable under the Medicaid program because in a lot of places Planned Parenthood is really the primary provider of those kinds of services. So that's the backstory. And so there were a number of states that passed various laws that in various ways would have knocked Planned Parenthood out as a provider. And Planned Parenthood brought actions in various courts to enforce the Medicaid any willing provider provision, and were successful in half a dozen cases. And then in the Eighth Circuit came out the opposite way. And not only did they say that that particular provision wasn't enforceable, but the theory that underpins that opinion would have implications for almost all Medicaid provisions. So effectively it would end individual enforcement of the Medicaid Act if the Supreme Court were to go as far as the Eighth Circuit did. Now, there is what's called a circuit split because some circuits have held that the provision is enforceable and others have said it's not enforceable. That means that the Supreme Court has the option of granting cert. And we don't know what they're going to do, but the fact that they have continued to turn it over to the next week's conference generally indicates that somebody's interested in it. The question is, are they getting ready to grant cert, or perhaps are they arguing about it and will ultimately the final decision be to deny cert? most likely with a dissent, which is why it's taking a long time.
Okay, great. Thank you so much. Let's see. Why don't I give another question, and then we'll start filtering through what people have been sending in. I know we've talked a lot about maybe things that aren't so great for public health that's happening on the federal level. Can either of you speak to things that maybe are productive happening on the federal level? I know that recently the SUPPORT Act was passed in response to the public health emergency over the opioid crisis. Do we see anything else, what positive is going on, basically?
This is Liz. So, unfortunately, the answer is not much. I do think that there will be continued movement on the opioid crisis because the SUPPORT Act is a promising start, but does not allocate nearly as much funding as is needed to address this crisis.
Mm-hmm.
I do think that with the takeover of the House by Democrats, we may see some proactive legislation around contraceptive coverage for service women using TRICARE and bringing that in line with the Affordable Care Act. It's, very tenuous and probably unlikely that that would pass in the Senate, but at least it sets a blueprint, and that is legislation from Jackie Spears' office. There's also been, so there's been two pieces of legislation introduced on over-the-counter birth control, and one is from Patty Murray's office, and one is from now non-representative Mia Love. And so the Mia Love legislation NHELP does not support because it doesn't address the insurance piece and kind of assumes that the magic of the market will ensure that over-the-counter contraception is affordable to all. But it does show, a willingness for a lot of people to embrace this idea of over-the-counter birth control, and whether that's going to happen at the FDA level, whether that's going to happen on the state level, or whether that's going to happen from the federal level, kind of still remains to be seen. So I think that's as positive as I can be about the reproductive health proactive pieces that I see coming out, as well as one other piece being now that the House has a lot of pro-reproductive justice supporters, there may be a lot more oversight of HHS and its actions to support or not support public health.
Okay, great. Thank you both. I see we have several questions coming in on the Q&A line, so I'll start off with one of our first ones. Where, if any, are there areas where both political parties, who often are at odds on a lot of different issues, can agree on related to reproductive health as public health?
Well, I know.
Start off with a difficult one.
Yeah.
I mean, I can give one area, which is in infant mortality. I think that is something that speaks to a lot of people. But when you try and unpack, and a lot of states have set up, especially, a lot of states in the South, like I know that Georgia has one, these perinatal quality committees, these infant mortality review committees. And when you kind of unpack and get to the root of that, there are a lot of things that maybe both parties don't want to address the same way, but it is an entry point that seems like a conversation that a lot of people want to have. And there are probably implications for why people think infant mortality is more important than talking about Medicaid writ large or abortion rights, and that is problematic as well. But I have seen a lot of states that are not the traditionally progressive states be able to kind of bridge the divide when it comes to decreasing infant mortality. And I think hopefully we'll see that with maternal mortality as well.
Okay. How will the flip in the House, will it improve prospects for funding for public health?
Because the House controls appropriations, then in some areas they may be able to have some leeway to revive funding. I think some of the barriers to funding can come from the Senate. However, for example, going back to some of the Affordable Care Act legislation, there were Senate bills that cut down on the risk adjustment ability, and that's part of the reason the premiums went so high. And so to my knowledge, the potential is there. To my knowledge, nobody has yet dug down into the details about what might be possible. And that's something that, just as a placeholder, we are interested in looking at and putting out as a blog post or an issue brief within the next few weeks. So watch this space for that.
Okay, great. And then also in terms of funding, we have a question about the status of teen pregnancy prevention grants, as well as efforts to terminate them or defund them. Can either of you speak to the status of such grants?
Unfortunately, this is not my area of expertise, but I would encourage people to check out Power to Decide, AMCHIP, which is the Association of Maternal and Child Health Professionals, ASTO, and maybe NIFRA, the National Family Planning and Reproductive Health Association. I think those are the people that will know a lot more about the actual appropriations of reproductive health funds.
Okay, great. Thank you. Now, a little bit on the Affordable Care Act and the marketplace. You have two questions related to this. The first is regarding the alternative health plans that have been advocated for by the requester thinks the executive office that are more restrictive, though cheaper than the Affordable Care Act in the marketplace. Do either of you have any thoughts on those?
Let me think about that for a minute. My understanding is that there is litigation challenging that, and so the question of whether those are going to be able to get anywhere is not just a question of legislation, but of whether the courts are going to find that it runs afoul of the Affordable Care Act.
And I'll just also add that a lot of the work that I do with NHELP is helping states improve or expand their benefit mandates to include reproductive health services that maybe the Affordable Care Act maybe doesn't include, and also just cementing that into state law in case something happens with the ACA. And so association health plans that could circumvent those benefit mandates kind of work against all of the things that I've been promoting.
Mm-hmm. Okay, then also related to the Affordable Care Act, as we all know, states are continuously suing to strike down the Affordable Care Act essentially, and we've seen places like Wisconsin trying to limit certain positions' power to pull out of those lawsuits. Do you think these lawsuits are going to continue? What are your thoughts?
Well, one lawsuit in particular is the one that's in the Texas District Court, where a number of states are making the argument that the elimination of the individual mandate, finding that's not means that other aspects, the entire Affordable Care Act, should come down, including the cost-sharing reductions. And so there are a number of states that are on those, that are plaintiffs in that state, that are not going to change. You know what I mean? So even if half of the states were to pull out and say they're not going to participate in the litigation anymore, there's still a critical mass of states that will do so. The Wisconsin question is interesting because I think people have heard that the legislature is trying to eliminate the ability of the Attorney General and Governor to withdraw from lawsuits. That will certainly be challenged as, unconstitutional under the state constitution. But regardless of how it comes out, there will always be Alabama and Texas involved in that lawsuit. and there are still enough states that they can continue in different directions to do that.
Thank you both. So for, everyone listening here, for those of us who want to kind of enact change and help, put forward more pro-public health policies, how would you suggest deciding whether to pursue a ballot initiative, legislation, or not purely, but an administrative policy change in the state? How do you kind of navigate what is best going to make the highest impact on the population?
Well, I think this is, and I'll be interested to hear what Liz says. I think this is, this is subject to debate. To me, ballot initiatives seem really powerful, and I think they're particularly potent right now because there is a disconnect between the majority opinion about, for example, whether Medicaid expansion is a good idea and the party affiliation of the government. It's a bipartisan, there's bipartisan support for the Medicaid expansion. And so rather than trying to figure out how to, convince your legislature or your governor, especially if they're not, if they're not in the party that's sympathetic to this, Idaho and Utah show, well, let's just take it to the voters.
So, I think that it's you should endeavor to do all three, is what I really want to say. But we're all human and we have, only so much time. So the ballot initiatives and the state legislative movement is something that you cannot do alone. You have to be a part of a coalition. You have to have, grassroots involvement. It really has to be, it's a long, time-consuming effort that is very worth it in the end if something comes out of it like Medicaid expansion. It's absolutely incredible, but it's not an easy fix and nothing's going to change tomorrow. So if you're someone who needs, really immediate fixes, maybe pursuing the small administrative changes is something that's a better fit for you. And the other thing about that is that that's something that you could do tomorrow. You can't get a ballot passed tomorrow, but you can look up exactly when the next public meeting of your MCAC is, the Medical Care Advisory Committee, which is mandated in every state. You can look up when the Board of Pharmacy in your state is meeting and go listen in on that meeting. Almost every state has these open meeting laws to encourage the public participation, and attendance is very low. As someone, who used to work for one of these public boards and speak at the public meetings, we take really seriously what people come to us and speak about, because if you take the time to come in, it means something really is worth paying attention to. So again, ideally you would do both, but they're two very different strategies, and they take different mindsets to be successful in both. So I would say to evaluate your strengths and also evaluate where you have relationships. If you're someone who is really great in the community, knows a ton of grassroots groups, ballot initiatives, that's what it sounds like to me. If you're someone who just happened to go to high school with someone who's now in the executive agency, you should be pursuing executive change. That sounds like a great fit for you. So it's all, and also be strategic about which ones to choose.
Great, thank you. Now I know we've talked a lot about the midterm elections' impact on the Affordable Care Act, Medicaid, reproductive health. What about impacts on the leadership or policy direction of the EPA?
I'll say that I have absolutely no expertise in this area. I don't know if you do, Sarah.
I'm not sure if Sarah, well, we can go on to a new question. It's definitely something to think about for all of us listening. Let's see here. In terms of collaborating on both sides of the, political aisle, do either of you have any suggestions to gain momentum and collaborate on these very challenging public health issues?
I wish I did. But I'd say sometimes just don't be afraid to disagree. And we had a conference this weekend, NHELP did, and someone was saying, even if you have a good relationship with your state Medicaid agency, you want to work together on these issues. You want to negotiate something out. Sometimes you just have to sue them. Sometimes you have to file a complaint, and that is the process that gets things moving. So, again, not to be afraid of challenging some assumptions and some practices that are immoral illegal. And by the same token, our speaker also said that agitation without relationship is irritation. So continuously agitating the other side, demanding what you want without ever getting to know the other people and where they're coming from is doing a real disservice to all of us in the public health community. So I'd say to keep those two things in mind. Yeah, agitation, but also relationship. Those are my keys. And I will say that I need to live them better myself.
Excellent advice. All right, I think we will end on that question. Thank you both so much. I'm going to pass it now back to Charles for some closing remarks.
Thank you, Chelsea, and thank you everyone for your participation in today's webinar, especially our panelists. I learned a lot, and I know our attendees did as well. So just a few final notes. If you submitted a question that did not get answered, we'll follow up with you over email addressing your question, and you can also feel free to submit any additional questions on the network's website by visiting our Ask a Question page, and we'll make sure that it gets forwarded to the right person. You'll also be receiving an email that will have a video playback of this webinar, as well as a link to our brief webinar survey. So we really value your thoughts about today's webinar and what topics you'd be interested in for future webinars. Also, if you're eligible, you will be receiving an email from ASLME with information on how to apply for CLE credits for this event. And finally, if you enjoyed this webinar, be sure to check out next week's event, Key Public Health Initiatives, A Year in Review, where speakers will recap how important public health initiatives from brain injury prevention to food insecurity and the SNAP program were impacted in this past year. So you can learn more by visiting networkforphl.org/webinars. And that concludes today's webinar. Thank you all for attending and have a great rest of your day.